I want to start by first just saying it's a great honor to be standing here and to join such an esteemed group of Canadian scholars in the Royal Society of Canada. This is also my first time in Banff, and I mean, I've seen photos of Banff, but it's just a beautiful place, although it is cold, right now anyway. I also just want to take a moment to just say how great it is to be here and away from some of the political shenanigans in Toronto that are going on right now. So psychology, in psychology, research is almost always a collaborative effort, and I can probably count on one or two hands the number of publications that I have that are sole author publications. So almost everything has been collaborative. So I also want to just take a moment to thank my students over the years, colleagues and mentors who have collaborated with me over the years. I also want to take a moment to thank Ryerson University, which has invested heavily in research over the past decade, and particularly in the Faculty of Arts and the department that I'm in psychology, where we've hired in psychology over 25 new faculty. We launched a bachelor's degree, master's degree, and PhD all in the last 7 years. So you know, we're always told, I don't know if it's true or not, but we're always told that we've been the fastest growing Faculty of Arts in Canada over the last number of years, and I really appreciate Ryerson's support of psychology and of social sciences in general. In terms of my research interests are quite broad within the area of anxiety and anxiety-based problems. So some of the work that I do is in social anxiety disorder, a problem. I'm a clinical psychologist, and in fact, probably the first 2/3 of my career have been spent in hospitals and in psychiatry departments in universities, and it's only the last 7 years that I've been in a psychology department at Ryerson. So social anxiety disorder, a problem where people have extreme social or performance anxiety to the point of it interfering with their lives, their relationships, and so on. Generalized anxiety disorder, a problem where people are excessively worried, and we all worry, but people with GAD tend to worry much more broadly. They worry about lots of different things. And again, to the point that the worry is interfering with their lives. It's affecting their sleep, their relationships, their work, and so on. And it's chronic worry. I also do work in panic disorder, a problem where people have rushes of panic out of the blue, that they may be sitting at home watching television and all of a sudden their heart starts pounding. They may feel like they're having a heart attack, or they're going to lose control or lose touch with reality or something like that. People with panic disorder also start to avoid situations. They develop agoraphobia, a fear of being in places where if they were to panic, it would be very difficult to escape or hard to get help. So they may start to avoid driving and flying and being alone and even leaving the house in some cases. I also do work in specific phobias. So fears of animals and insects and blood and needles and driving and flying and heights, the sort of situations that people think about when they think of phobias. I've also, over the years, done work, and particularly more recently, in the area of perfectionism. So a tendency to hold unreasonably high standards, something that I'm sure nobody here is familiar with. In the case of the perfectionism I'm interested in really is clinical perfectionism that paralyzes people, not the kind of perfectionism that leads to success, but perfectionism that leads people to procrastinate, perfectionism that leads people to feel devastated when they don't meet one of their impossibly high standards. I also do work in obsessive-compulsive disorder, so a problem where people have intrusive thoughts, images, and urges that they find frightening or distasteful, and they engage in repetitive rituals, washing their hands over and over again, checking things, correcting things over and over again. And then finally begun to do a little bit of work in the area of hoarding as well, which used to be often classified as part of OCD. As of May, the new Diagnostic and Statistical Manual of Mental Disorders was published, and hoarding disorder is now a brand new condition that was invented in May. So my interests really span those broad areas, and the domains that I study within those areas include treatment effectiveness, so developing and studying ways of intervening and helping people to reduce the impact of some of these problems. These are chronic problems, so they do tend to continue over time. Even with treatment, most people still have symptoms that they struggle with. But instead of their OCD taking up 10 hours a day, it might be taking up an hour or two a day, and their relationships are better and they're back to work. And really the goal of treatment is to help people to function better. It's not necessarily to get rid of a problem. Mechanisms underlying change during treatment is another interest of mine. Knowledge translation. I hadn't really put this together for myself until I heard somebody introduce me at a talk, and they described me as somebody who takes research basically and makes it available to people who are administering treatment, so frontline clinicians, and to patients who are dealing with these kinds of problems. And I guess a lot of the work, in retrospect, a lot of the work that I do is focused on making the research accessible to people in the community. Evidence-based assessment as well, and then the correlates and causes of anxiety-based problems. And my work really spans the range of different causes. So I look certainly at cognitive factors that contribute to anxiety. I look at personality factors, social factors, experiences that people have, and biological factors. And just to go through briefly each of those areas, just to give you a few examples of the kinds of things that we're doing. In terms of treatment effectiveness, one area that we've been looking at recently is an area called motivational interviewing. Motivational interviewing is a strategy for helping people to resolve ambivalence about treatment. With a lot of problems that people have, and this work started really in substance use problems and also in helping people to improve their healthcare behaviors, being compliant with medication, exercising, eating more healthy. With a lot of those kinds of problems, people are ambivalent about change. On the one hand, they want to feel better, they want to drink less, for example. On the other hand, their whole social life may surround drinking. They may not even know what it's like not to be drinking. They enjoy the drinking, for example. And the same with healthcare behaviors. On the one hand, people want to be healthy, they want to be physically fit. On the other hand, they hate exercise. And so they're ambivalent about changing. And motivational interviewing is a strategy for helping people to resolve that ambivalence. So one of the things we do, for example, is help people to look at the costs and benefits of changing. We help people to look for intrinsic reasons for changing, rather than changing because your family is wanting you to change, for example, which would be more of an extrinsic reason. We help address fears that people have of changing. And it's done in a very sort of client-centered way. So the therapist is not coming at the client as an expert telling them that you need to do these things. It's very much drawing on the client's expertise. And it's only really recently that motivational interviewing has been applied to anxiety-based problems. And some of our work has looked at motivational interviewing in OCD and has found that a few sessions of motivational interviewing before people begin an evidence-based treatment for obsessive-compulsive disorder leads to better outcomes during that evidence-based treatment. And we're now looking at that in generalized anxiety disorder as well. We've looked at home-based treatments of obsessive-compulsive disorder, and we've also looked at an exposure-based treatment for panic disorder. So, for example, we know for a lot of phobias, the most effective way of overcoming fear is through exposure, doing the thing that you're afraid of. And there's a whole bunch of strategies that we use to help people to do that. In panic disorder, what people are afraid of is not an object or situation. They're afraid of how they feel in situations. People with panic disorder are afraid of their fear, essentially. They're afraid of that racing heart because it might lead to a heart attack or something like that. And what we've done is we've helped people to systematically bring on those symptoms that they fear until they're not afraid of them anymore. So spinning around to get dizzy, running on the spot to get people's heart rate going, until they're not afraid of the symptoms anymore. And then what happens when they're not afraid of the symptoms is they don't get those panic attacks as frequently, and if they do get one, they don't care as much. In terms of, so that's a little bit on sort of treatment intervention work that I do. We also look at the mechanisms underlying change. So, for example, one recent study that we published looked at the role of safety behaviors and how they affect exposure-based treatments. So in this case, it was using spiders. And what we found is that as I mentioned earlier, exposure to spiders is a helpful way of overcoming the fear. But if people use safety behaviors, they do little things to protect themselves during that exposure. So, for example, they make sure they're wearing long pants so spiders won't get on them and so on. Those safety behaviors may undermine the effects of exposure-based treatments. In terms of knowledge translation, we've done a little bit of research on that, but a lot of the work I've done there has really been taking the work that we've done and that a lot of others have done and turning them into manuals that, again, clients can use and that therapists can use to administer these various treatments. terms of correlates and causes of anxiety, there's a wide range of different studies over the years that we've done. One project that I'm very excited about now is looking at digital hoarding. Another thing that I'm sure nobody here does. So, you know, we talk about hoarding often as sort of material hoarding. So people who, you know, bring lots of stuff into their house and can't get around their homes and can't throw things away. A lot of us also spend a lot of time hoarding digital materials. It may be MP3 music files, it may be PDFs, and they don't take up a lot of space. We have the room for them, but they take up a lot of time, that kind of hoarding. And people may spend a lot of time organizing these things to the point of it being a problem for them. And it's only recently, actually there have been no studies on this, and we're beginning to collect some data for the first time on this. We've looked at the role of teasing and how that affects development of anxiety problems later on. To get rid of a problem. We've looked at the role members may subtly encourage or enable people who hoard. And actually lead to an increase or at least a maintenance of the problem. And now we're also beginning to look at the role of insight in obsessive-compulsive disorder and some of the factors that contribute to whether an individual with OCD recognizes that their problem is excessive or whether they see it as a perfectly normal, helpful way to think about things. And we're looking both at psychological factors contributing to insight as well as neuropsychological factors, so brain function and how that relates to insight. And then one last study I'll just mention is a study that one of our graduate students is doing for his dissertation. It's a study on religiosity, spirituality, and obsessive-compulsive disorder. You might think that people with obsessive-compulsive disorder, because there's a lot of ritual in OCD, and there's also a lot of ritual in religion, that the two might go together. It turns out that people with OCD are no more likely to be very religious than people without OCD. However, if they do have OCD, people with OCD are more likely to have religious content in their obsessional thoughts and behaviors than people who have OCD who are not very religious, who are more likely concerned about contamination or other sorts of content. So this particular project will be looking at the relationship between religiosity, spirituality, and OCD in a much more in-depth way, measuring religiosity much more carefully than it's been measured before, because again, there's lots of different ways of thinking about religiosity and spirituality. So I think I will stop there because I have no idea what time I started. So hopefully it's been about the right amount of time. And again, I just want to thank the Royal Society of Canada and the Academy of Social Sciences for electing me to the Society. It's a great honor. Thank you.